This is an effort that we put together with the Department of Pain Medicine and Palliative Care, the Research Division, and the Office of Grants and Research Administration here at BI. What we do is we focus on research issues and try to build up a base so people can understand and get acquainted with the challenges that we might encounter with this type of discipline. Today we are very fortunate to have here Dr. Ronald Blum, who is the Professor of Medicine at Albert Einstein College of Medicine, and he is the Director of Cancer Centers and Programs at Beth Israel Medical Center and St. Luke's Roosevelt Hospital Center. And he's going to be talking about challenges that we encounter in research related to cancer. Thank you, Dr. Blum.
Dr. Cresciani, thank you, Ricardo. So I'm it's great to do this lecture for a number of reasons, but certainly in the context of a broad program through Continuum Health Partners and research that covers a lot of disciplines, and the idea obviously is to be able to present some best practices across disciplines. So the learning objectives are, first of all, to understand the context and challenges of cancer clinical trials, to learn a little bit about clinical trial design for the cancer studies in particular, to focus on some of the statistical considerations in the context of the broader symposium or forum that's been going on, but to illustrate some points about cancer clinical trial. Clinical meaningfulness is a very important aspect of what the output is, if you will, from clinical trials, particularly with healthcare reform, which we're all committed to. I want to tell you a little bit about our own program here at the Continuum Cancer Centers of New York, and then, but to put this in a context, I've been doing this for a long time. I had the good fortune in 1971 of being drafted by the United States Public Health Service as opposed to going to Vietnam, which landed me at the National Cancer Institute exactly at the time that the Cancer Act was signed by President Nixon, and I really divide cancer research into the first 30 years up until the millennium. And in the first 30 years, the cancer war, as it's been called, focused really on drug screening, on analog development. It was totally empiric, based really on trying to get the most as we could out of combination chemotherapy, dose, schedule, combined modality, and tried to reduce treatment effects. And there were advances, although they were very small indeed. The change really came with this landmark paper in 2000 by Dr. Weinberg and group at the MIT. And basically what they did is they defined various targets for molecular biology in cancer and totally changed the way we look at cancer, cancer medicine, and as a result, cancer clinical trials. So rather than focusing on the cancer cell, which had been the original focus of the first 30 years of the research, at least, that I participated in, but began to look at the cancer cell in the context of the environment that it sits in, and then a variety of factors that relate to the transformed cell from a normal to a cancer cell, with the opportunity for targeting, if you will, these various molecular changes in the normal cell that could be targeted for therapeutics. This slide is more than 10 years old and represents a map, if you will, of signaling in the cancer cell. And then superimposed on this is the next slide, which were agents in development. They're still in development, but many of these agents are now part of, if you will, the standard of care for cancer. And all this has evolved relatively quickly. So the challenge for clinical trial design is there's been an explosion, literal explosion. We have finite resources. Eligible patients now are not only defined by the conventional characteristics, but increasingly are defined by their molecular genetic characteristics. And certainly as you begin to subset patients out, example that some of these gene transformations occur in maybe 10% example of, say, patients with lung cancer. And we have finite resources in terms of infrastructure. This is expensive in all aspects, and this is a challenge that we have. The expense of clinical trials is huge. on the part of the sponsor, and frankly on our part as well as investigators. Lead time, terrible in terms of the amount of time it takes from an idea through preclinical, clinical development, the regulatory issues. I sit in the COSA in our IRB, and it's a challenge to try and expedite things in a real time. Pharma has its agenda. It may not always align with ours as clinicians and investigators. And then, of course, the regulatory issues. The main regulatory issue in the U.S., the FDA, their mission is to prevent harm to patients, not necessarily to bring new drugs that provide benefit. So I borrowed this slide from Dr. John Mendelsohn, formerly president of the MD Anderson Cancer Center, now involved very much in this phase of his career in personalized cancer therapy, and presents a very good paradigm. That is, with a gene array, we've now actually identified what we think are most of the abnormalities that cause cancer. There are 800 new drugs that are available for clinical trials. And what you can do in real time, and there's actually just an article in the Times over the weekend, that now being able to sequence an individual patient and his or her tumor is now available in real time at relatively finite cost, like $5,000. And that's going to change things dramatically. So there are multiple proofs of principle. If you notice, all of these papers are in the New England Journal. There are others. This slide is now almost a year old, and there have been several other molecularly defined targets with proof of principle of efficacy leading to a regulatory approval in the United States and worldwide. Now, one of the issues that we face is clinical trial participation. There are about 8,000 clinical trials available in the United States. But the reality is only about 2 to 4% at best estimates of adults who are eligible for clinical trials enter clinical trials. So there are many barriers. One of them is the patient barrier, and patients are reluctant. Lots of extra appointments, which sometimes are true or not true, but perceived. Commitment of time and costs. Travel costs are huge problems. As the price of gas goes up, or if you will, as the cost of the MetroCard goes up, whichever the community. And there's certainly residual uncertainty about suspicion of medical research. And this is a very complicated and interesting topic that we've had some interest in. There are also physician barriers. We as investigators, there's no question that there's an additional burden required on the part of the investigator. Often our clinicians are not aware of clinical trials, and frankly, there's loss of autonomy. And that is, you're not the decider, but rather the clinical protocol often makes the decision. So what have we done? What can be done to increase physician participation? One is to create an academic culture. There are those of us who get a rush from discovery, from putting together an idea, and actually being able to apply that in a clinical setting. There are incentives. The program, at least in our division now, is evaluating the faculty on the basis of their participation in clinical research. An infrastructure, and I'll talk about that towards the end. We think we're well on our way to developing an infrastructure that increases physician participation. A portfolio, we have lots of clinical trials available, and certainly to get physicians interested, you've got to have a critical mass of activity, and I'll show you that towards the end. And then patient awareness. And so among my favorite tricks, ask me about clinical trials. You can see I wore my regular lab coat. It's a little brown along the edges because it's not clean, but this button is something that's on. And you'll be surprised how many times I get stopped either by my colleagues or by patients and their families. So tell me about clinical trials, and it's a great entree. And these buttons are widely available. One of my heroes is Alvin Feinstein, who is an epidemiologist and practiced at Yale for many years, died a couple of years ago, but brought a very broad concept to medical epidemiology and in particularly clinical trials. And the quote from him is, "The opinions of experts has been a traditional source of all the errors throughout medical history." So there's a difference between evidence-based medicine and the expert. And we all think we're experts, and we're responsible for a lot of errors, if you will. So one of the key points in my clinical practice is the informed shared medical decision-making process. And these are the elements of it. And one of the key elements in trying to work with patients to get them to a shared informed medical decision is obviously they need to be informed. And you've got to get permission from patients when you enter into a discussion about a clinical trial or any pivotal decision. It has to be shared. There's no longer physician autonomy for sure, and there shouldn't be patient autonomy, but rather a shared medical decision. And then in the context of this discussion, there's evidence-based medicine at one extreme, and there's the expert opinion at the other. And obviously, this is a time to talk about evidence-based medicine and brings into the immediate discussion of a clinical trial, which is based on evidence-based medicine, although always there's expert opinion. And of course, to talk about what the patient preference is in a given clinical setting. So this is a pivotal moment, if you will, in the decision making with respect to clinical trials. Now this is a very important slide in trying to understand healthcare economics, trying to understand clinical decision making and clinical research. I borrow very heavily from Zeke Emanuel, who some of you in palliative medicine know his work in terms of the ethics and end-of-life issues, but he has had a significant impact in terms of the healthcare reform that's currently under discussion. And he describes things that are high cost, low value. And he's particularly critical, and I support that, of my colleagues who engage in clinical treatment that has huge costs. And we use a new drug that has a high cost but very low value in terms of its benefit to patients. High value, low cost, that's straightforward. If you have something that works very well and doesn't cost much, then that's a very clear clinical path. On the other hand, there are high value and high costs, and that's a very important issue facing us in research and also in healthcare economics. So when you look at the current issue, and this is really in the context of healthcare reform, that cancer drug pricing is unsustainable. It's about $100,000 for many of these drugs a year for the cost to the system, often with copays to the patient. And the rising costs are being driven by expensive therapies that have marginal benefit, used off-label. So you may see improvement in survival of a couple of months costing about $100,000. And what's important to point out is that clinical trials, particularly in the cancer, but also in other fields, are being designed really to look at statistical significance rather than what the meaningful use is, what their benefit is, what their cost is in this particular paradigm. So I borrow from the New York Times. I also quote Sam Waksal, a man who's been rather controversial. At the bottom it says he was indicted for insider trading and convicted and spent time in jail. He's the guy who did inside trading for Martha Stewart's drug, Erbitux, a drug that's in clinical trial. And he proposes in his op-ed last week saying we should only pay for drugs that help people. So the idea is that you put a patient on a drug, if it works, fine, everyone wants to pay for it. It's high value and high cost, but if it doesn't work, then it shouldn't get paid for. It's a very provocative way of trying to look at what the goals of clinical research should be and how we can drive, if you will, a sustainable economic model. So this is a slide in terms of clinical trial design, familiar to all of you. You can look back at data, mine it, and come up with, if you will, hypothesis-generating ideas. You can do prospective trials, which can be concurrent or can be controlled, randomized controlled. You're all familiar with the various phases. Phase 1 is really designed to establish toxicity and what's a reasonable dose and schedule. Phase 2 is in a purer population, identify whether or not there's a therapy signal. Phase 3 is a randomized clinical trial with a standard and a comparator, usually the experimental arm. And phase 4 are post-marketing studies that are done to confirm various aspects that are being looked at as significant. Now, if you look at the single-arm study, in this context, so-called phase 2 studies, patient selection is an enormous factor because you have the ability to not take all comers, but rather to select a subset for one reason or another might be give you a good result. There's enormous bias because the investigator, more likely than not, would like it to be a positive study. Interpretation of results are flawed because often there aren't pre-planned analyses, so that if you do things enough, you can obviously come up with the answer you're looking for. And a very important issue is publication bias, and that is that there are many phase 2 single-arm studies that are done that turn out to be negative, quote unquote, and never get to the press. And those that are positive or marginally positive, they do get published. And so there is no journal of negative results for these kinds of studies. This point is made in terms of the limitations of phase 2 studies. A study was done of 100 clinical trials that were presented at our national meeting. I would say international meeting of ASCO, the American Society of Clinical Oncology, and then look down the road 15 years later. How many of those phase 2 studies actually went to phase 3 study, to a proper control study? And it's a challenging number. It's 13%. Making the point is that there's a lot of single-arm studies that don't get the scrutiny of phase 3, are accepted as quote-unquote expert, and really are not evidence-based, but yet may well drive clinical decision-making. So there's a series of things I want to bring up in terms of concurrent controls. There's a wonderful concept called iotropic stimulus, coming again from Dr. Feinstein. We all know iatrogenic, physician-caused. Iotropic stimulus is that attraction to a particular doctor at a particular point in time. And conceptually, it really frames the dynamic of clinical practice. So if you're in an emergency room and a patient comes to you, you say, why did you come tonight and not yesterday or the day before? And it may be because my pain is crescendoing, or I could finally talk my son-in-law, that bum, into driving me to the emergency room. So what does this have to do with clinical trials? So if you look at series of experiments, and I'll take two extremes. One is our local VA hospital, the Manhattan VA hospital, where I've worked at, just up the street. What's the iotropic to the VA hospital in Manhattan? Well, likely the ambulance will take you there because you say you're a vet, you don't have insurance, and you show up at the door with a high degree probability of tobacco abuse, among other things. By contrast, the Mayo Clinic, what's the iotropic stimulus that gets you to the Mayo Clinic in Rochester, Minnesota? A first-class plane ticket. So if you look at studies that are done at those two institutions, the iotropic stimulus is so different that in fact you have enormous bias, even though there's concurrent controls. Comparability of groups. We think we understand important prognostic variables and outcome predictive variables. If you look at tables in phase 3 clinical trials, you really have to look very carefully to make sure that group A and group B are comparable by those variables that we think are important. But obviously now with molecular medicine, as we begin to subtype, in fact, they may not be comparable. And then there's the Will Rogers phenomena. Again, it's a Feinstein concept. What did Will Rogers have to say? And I always have to be careful. There's nobody here from Oklahoma. I can't tell for those who are seeing this on the web, and I apologize for provincialism, but Will Rogers said, if you take all the dummies from Oklahoma and move them to California, you raise the collective IQ of both populations. So the idea here is, obviously, if you've got a group of people and you take out the poor prognostic low IQ and move them to California, the IQ is even lower in California. So the idea then is that there is a shift by upstaging, by more the ability to winnow out those patients that have a poorer risk. And with increased ability to subset patients, Will Rogers phenomena has a clear effect on trials, even though they're randomized. In fact, you can't go back and make comparisons. Will Rogers. Equipoise, a very important concept. So equipoise is that ethical situation where you as an investigator don't have a bias. You have comfort that either arm, A or B, the standard or the experimental, could be a benefit. If you know the answer, then you're not at equipoise, and then you shouldn't be doing the clinical trial. And so one of the key questions in understanding a randomized trial is whether or not you and others are at equipoise with respect to the question being asked and the potential risk and benefit to the patient. Randomization is a complicated dynamic and upsets a lot of people. Okay, doc, I'm willing to go into the study, but I really want treatment A or treatment B. And this is a pivotal concept, the loss of control on you as the part of the investigator and the loss of control on the part of the patient, because they may not be at equipoise or you may not be at equipoise. So everybody's got to be cool. They got to be at equipoise. Otherwise, you can't enter a patient in a randomized trial. Placebo, another very difficult issue, particularly for cancer. And the trial that has been used as an example of the challenge was in a gastrointestinal stromal tumor study, a disease for which we had no real treatment. Primary treatment, the imatinib, works well in most patients. There are a subset of patients that have progressive disease. A new drug became available, and so the study design was a placebo-controlled, double-blind, active treatment for patients who had rapidly progressive cancer versus placebo. Ethical? Not ethical. Equipoise? Not equipoise. The key, and I was actually chair of the Data Safety Monitoring Board on that study, the key was that we used a progression-free interval with multiple statistically powered early looks. And at the first look, there was a dramatic difference in between placebo and the active treatment. And within a day, the FDA approved the drug. The blind was broken. Patients on placebo got active drug. The drug came to market very quickly. It's true that some patients probably died because they got placebo, but the outcome, one could argue, was of overall benefit globally, perhaps not to those individual patients, but globally, because it gave a strong evidence base for the efficacy of this drug in this setting. So I just want to pause briefly and talk about data safety monitoring boards. It's an area that I've become very interested in. Some will perceive expert. I sit on a lot of them. It's being required by regulatory agents as a way of independently looking at clinical trials, phase 3 clinical trials. The sponsor gets to appoint the membership in this group. Data safety monitoring boards are independent, serve at the pleasure of the sponsor. You can tell the sponsor something and they don't need to listen to you, but that's generally not thought to be good form. But what data safety monitoring boards do is they first of all look at toxicity to make sure that subjects are not being put at harm beyond what could be the potential benefit, to look at treatment effects so that there's opportunities in statistical context to determine that one arm is better than the other, or as recently happened, the experimental arm turned out to be vastly inferior to the control arm at early look and the study was closed, or futility. There's no way, if the study continues to completion, that there'll be a fulfillment of the pre-design efficacy hypothesis. So these are very important and very common, required really by the FDA. So let me take a few minutes now and talk about endpoints and to focus on cancer in particular because of the notion that we're beginning to appreciate of the importance of differentiating between tumor-centered versus patient-centered endpoints. So of course, overall survival is an important benchmark. from a clinical trial standpoint, fortunately, there's a bit of a paradox here, from a clinical trial standpoint, cancer, many of the cancers we treat, death comes fairly early, so it's a reasonable endpoint to use. There's a lot of controversy around using time to an event. So part of the bevacizumab, Avastin controversy that's been going on for the last year or two has focused on the use of progression-free survival as an endpoint. And it's a complicated point, but one that has caused a great deal of discussion whether or not progression-free survival is a valid surrogate endpoint for other important endpoints like overall survival. We have objective criteria, internationally accepted, called RECIST, which basically codifies objective measures of tumor through imaging studies, through palpation, through tumor markers, and is widely accepted in a difficult endpoint to hit, but one that's used. The so-called waterfall plot has evolved out of essentially targeted therapy. Targeted therapy may not necessarily cause the tumor cell to die and therefore shrink and cause a decrease in size by RECIST criteria, but may stabilize. So again, using imatinib as an example, imatinib shuts off phosphorylation, stops the tumor from growing, but does not cause the tumor to shrink. So that what you have then is stabilization of disease, and I have patients now on 10 years who have metastatic disease who are absolutely stable when historically they would have died within months. So this is an example of trying to look at the RECIST criteria in the context of these patients here. This is with therapy showing the difference here that there is benefit for this group of patients even though they don't have the full RECIST criteria in terms of benefit. So functional imaging. Increasingly, we now can recognize PET and other radiolabels of functional imaging as being valid surrogate endpoints for clinical benefit. Easy, faster, expensive, but nevertheless an early way and a consistent way to establish response. We have a series of surrogate endpoints, example tumor markers that we use in our clinical trials. And then the last point I want to make is that we do use quality of life measures, and presumably this is patient-centered. The idea that instead of asking doctors to report or clinical invest, ask the patient, what's been the impact? And this has been a very powerful focusing example in prostate cancer, when some of the very troublesome side effects associated with prostate cancer therapy, impotence, incontinence, etc., ask the patient and you get a much different point of view. So there's increasing emphasis on using patient-centered endpoints as a valid endpoint in trying to understand, if you will, what the benefit and cost is. Now there's a very troublesome trend in phase 3 clinical studies in cancer. And this was a paper that was published in 2008. First of all, the sponsorship of clinical trials has shifted from governmental to pharma. The tendency to use RECIST criteria has gone down. The time to an event, progression-free survival, has gone up. The effect size has stayed stable. So that we're not looking for big changes. In fact, we're looking for small changes. And that's troublesome in a number of ways. So this is, if you will, a transition to some statistical considerations. The assumption is you're familiar with all these terms. I just want to point out some in the context of clinical trials and some of the challenges. So the p-value, if it's more than 0.05, less than 0.05, then it's significant. So we go to our big national meetings and there may be 3,000 papers, I'm going to say 1,000 to make the math easy, that are presented. By chance alone, 50 of those are going to be false positive if you use the 0.05. If you use only p-value with a large study, there may be a hugely significant difference, but the effect size may be a month or 2 minutes benefit. Type 1 and type 2 error. So type 1 is the p-value. That is, that there's the chance you're seeing, the difference you're seeing could be by chance alone. So at 0.05, it's 5% chance. And as given the example I just showed you or used, that's a lot. It could be 50 papers a year at national meetings. Type 2 error is because of the resources required. Often there are differences, but the study's not big enough. So you don't have enough sample size to be able to flush out a difference when there is one, when the differences are small. And I'll illustrate that in a moment. Now, hazard ratio is something that is widely misunderstood. So this is an attempt to just briefly show you 2 studies and trying to identify what the hazard ratio is. So if you go to the time at median survival, you can then drop 2 lines. One, the blue line, which turns out to be about 23%, or the red line, which turns out to be 29%. And so that gives you a hazard ratio of 0.69. Yet the difference is relatively small in absolute terms. So it's numerator denominator over 2 results. And a confidence interval around it becomes important because often they're wide confidence intervals, depending on the sample size. So this is a metric that's often used and has flaws. A second place where, or another place where statistics are used to lie, or at least not to tell the full truth, is absolute versus relative benefit. So the treatment I'm about to recommend to you is going to give you a 50% chance of improvement. Ooh, wait a minute. Are you talking about absolute or are you talking about relative? So if there are 100 patients like you, and let's use adjuvant treatment, 50 are going to survive without any additional treatment. If the absolute benefit is 25%, the relative benefit in this hypothetical is 50%. The reality is that 75 patients are going to derive no benefit. 25% of patients will derive benefit. All will have toxicity. So 1 in 5 patients are going to be benefited. That's different than 50% of patients are going to be benefited. And there's got to be truth, if you will, in the informed shared medical decision making of what the absolute benefit is, talked about in real units of time. And I can venture to say that this is not the standard, but yet should be truth-telling in informed shared medical decision making, and our clinical trials really need to focus on that, if you will, absolute benefit. Intent to treat, a very important point, particularly in complex patients with comorbidities, other issues going on, and that is if they get randomized, they get analyzed. And a lot of funniness can be done in terms of data analysis to only show those patients that were eligible or some other gleaning from the data set to give the desired results. And then meta-analysis I know you've talked about, but this is a study that I use in soft tissue sarcomas. And you can, one of the problems is that they're rare cancers. And so most of the study, all the studies that have been done and are being done suffer from beta error. Small differences and not enough sample size. So you can do a meta-analysis. You could try to pool it all together. And you can see here that in a meta-analysis, whoops, got to go back. In a meta-analysis, clearly the hazard ratio is significant, doesn't cross 1. And these are all the other studies showing very broad confidence intervals, again because of small sample size. But when you pare down, the absolute benefit is 5%. Yet my colleagues might say that there's a 70% benefit, the hazard ratio of 0.7. or 30% improvement. But the absolute benefit is 5%. So what about clinical meaningful treatment effects? Healthcare reform, but also what should we be doing, at least in cancer clinical trials, to try and provide the maximum amount of benefit, particularly in this context of molecular biology. So sample size considerations is a huge issue. Again, finite resources. And we're talking about enriching a population of patients who have not only, if you will, phenotypic characteristics, their cancer type, their performance status, their age, but now genotypic characteristics. Do they have a mutation or don't they have a mutation? And in trying to figure out sample size, that's a consideration. What's the available population? Another consideration is what treatment effect are you looking for? Are you looking for small differences or are you looking for big differences? If you're looking for big differences, then you have to have a much larger sample size. I'm sorry. Yes, that's right. If you're looking for big differences, you can have a small sample size because that will come out. And so many of these trials are designed to look at big differences with small sample size and don't meet their endpoint. Yet, if you look at small differences, then you need huge a sample size in order to show that difference. And so this is a big consideration. Benefit versus cost of the drug, cost of toxicity. All those things have to come into consideration. And then, if you will, to use the terminology of comparative effectiveness, you have to put that in context. And I know that was discussed by previous speakers, but the difference between efficacy, and that's a rigorous clinical trial under the conditions that we've just talked about, effectiveness, and that is might come out in a phase 4 post-marketing, or the generalizability of the data to a larger population, a more general population. And then the efficiency in terms of clinical meaningfulness is it worth it? Is it a high cost, low benefit, high cost, high benefit, or ideally low cost, high benefit? And that's the whole concept of comparative effectiveness, and our clinical trials have to be talked about in that context. Now I want to shift a little bit to our program here at Continuum. And the strongest argument that's made to our patients/subjects is that things are happening very quickly. The development of new cancer treatments is explosive. The only way to access these agents is through a clinical trial. Well, do I need to go, can I get it, I know my congressman, could I get it that way, et cetera, et cetera? The answer is, for the most part, no. And that's been a fairly strong ethic in the pharma and in government, that in order to get access to these trials that are not approved, you really do need to go through a clinical trial. And fortunately, we have clinical trials that are available at all of the Continuum sites. We have a totally integrated system. It's interdisciplinary with participation by all of the disciplines. We have radiology studies, pathology, surgical, medical, radiation oncology, and supportive care studies. It's a core resource modeled very much after NCI designated centers. Although Continuum is not a designated center, this research program is modeled after that as a core resource available to any investigator who is doing cancer-related research can come to this core resource and get support. It's self-funded. I must say that we get no hard funding. It's all self-funded through the income received from clinical trials. We have about 12 FTEs in the program, and it, from many perspectives, is successful. So what we've done is we've developed a protocol development system that requires disease-specific experts to come up with the idea, to vet it, to make sure that there is merit to what they want to do, be it an investigator-initiated research, be it from pharma or from a national cooperative clinical trial. We have a monthly research meeting that everybody participates. We take a look at each protocol and use 3 fundamental criteria. One is the investigator enthusiasm. If the investigator is not enthusiastic, if the people who are going to be enrolling into the clinical trial are enthusiastic, and I mean, yeah, we really got to do this, as opposed, I'll participate. Because without investigator enthusiasm, studies don't accrue. The available subjects. And again, the challenge is that because we have so many eligibility criteria, particularly in the molecular era, this becomes a challenge to try and figure out, A, do we have eligible subjects, and B, are they willing to enroll, given all the barriers that we all know exist in the enrollment in clinical trials. And the third is kind of my favorite, what's the deal? And the deal is we have the luxury of having flexibility. And the deal could be, what's the programmatic importance? How does this fit into what else we're trying to do in our cancer program, the Continuum Cancer Centers of New York? The deal could be financial. Some studies pay extremely well, ridiculously well. Some don't. Some pay ridiculously little in terms of the time and effort. And a variety of other factors that go into the deal. And so we've used this as a way of trying to come up with studies that will accrue, ask an important question, and frankly, keep the program self-sustaining. COSA is an issue. Patricia, who's sitting in the front row, runs our regulatory program, is phenomenal. But the boxes of paper that go into COSA on a monthly basis is just mind-boggling. COSA can tell us anything they want. If they want the informed consent to say you got to jump 10 feet, then we've got to put that into the documentation. It's not a question of how about 6 feet, you got to jump 10 feet. And the way that IRBs are designed is to give autonomy to each of the IRBs in their own clinical setting to request whatever they want. And that's caused some real challenges. I must say, though, with great respect to Arnold Winston and his staff, that our COSA process is really quite facilitated and quite reasonable. And then activation, all the issues that go into actually putting the trial out there, enrolling, defining eligibility, and implementing and analyzing clinical trials is an enormous challenge. So we have a portfolio of studies that for some are investigator-initiated. They're often lost leaders. That is, we have no funding for them. Clinical research is very hard to get funded, as is other research, with funding levels nationally at the 10% level. NCI continues to support cooperative groups, so we're members of multiple cooperative groups. We have requirements to enter a couple of patients a year or a given number in order to keep our membership. They don't pay very well, but there is programmatic value because it does give us access to national standards of clinical research. Pharma is a slippery slope. The relationship, often these studies are marketing studies. The incentives don't always align with what we consider good practice. And so it's a very complicated dynamic that we try and balance in our development of clinical trials. To give you a sense of some of our statistics, there are 180 protocols. Patricia, I don't know if you've counted them lately, but that's pretty close, that are active in our portfolio. We have about 80 studies that are open as we speak today. We have to continue to follow up on protocols that we had open in the past where patients are still in follow-up. For adjuvant studies, this can go on for 10 and 20 years. And we have a portfolio of 26 protocols at the point in time at the end of the year that are in active development at some point. So this is a huge process to try and manage. And again, incredible appreciation for the complexity and effort on Margarita Gildova, who's the senior manager of the program, and at least two of the people are in the room here who manage this program, and it's a great pleasure to be able to speak for them. So the rubber hits the road. What's the accrual statistics? And you can see for 2011 and 2010, we've enrolled a fair number of patients into clinical trials, far exceeding the accreditation requirement for our American College of Surgery Network Cancer Center, which requires a given number. We're far above it. We get commendation, and the contributors to that are many. This just gives you an idea of the breadth and depth, if you will, of our protocol research. A significant number of our accrual does come for observational studies, but a statistic that I'm very proud of is nearly 200 subjects are enrolled in therapeutic studies. Again, the goal is to make cancer treatment better for more patients, and this is a number that we're very pleased about. We post our protocol priority list on the web. We distribute it in a number of different ways. You can't read this, but this just gives you a snippet of exemplar breast protocols that are out there, showing you basic information that's available to our investigators and to the public on the Continuum website that helps you identify all of these protocols. But the key step, as we try and reinforce to our colleagues, is first of all, you've got to bring up the subject at a pivotal meeting. Is this patient a potential subject for a clinical trial? And if so, then to go to the research office. And obviously, we want our patients to ask the question, we're making a treatment decision, is a clinical trial an option for me? And I can't tell you how many times I've been in the awkward position. A patient asked me that, and I said, I forgot to look at the protocol priority. I look at it, run into the office and say, is this patient eligible? May or may not be, but I think that's an important part of the dynamic. So I tried to cover some of the objectives to give you a context of where we are in our clinical trials today. Talk to you a little bit about the clinical trial design for the cancer patient. Focus on some of the statistical issues. Get into the issue of clinical meaningfulness in the specific context of cancer clinical trials, but in the broader context of healthcare reform. Tell you a little bit about our own research program. So this is one of my favorite slides. Terry just went to Antarctica. I used to use the Antarctica slide, but this is Petra in Jordan, and this is a city that was built before the Common Era, was uncovered about 100 years ago and mined. This is my wife here in this little spot down here. I can't get the pointer to work, but this little person sitting by the rock. And I use this to put it in a broad context, that we're just but a speck. This was built many, many years ago. Our attempts to try and improve cancer treatment are, again, just a speck. And in the context of the broader symposium, it's a very complicated area. And I hope at least I've begun to give you just a little bit of some of the challenges, and hope that inspired you to continue to have the thrill of discovery as I've had the good fortune to have in my clinical career. Thank you.
Thank you very much for an excellent presentation. Questions?